and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and chapter immunization representative at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic. This is the week of June 21st, 2021, and globally, the world is at almost 179 million total cases from the start of the COVID-19 pandemic, with almost 9 million deaths worldwide. In the United States alone, we are at 33,560,000 total cases, and unfortunately have crossed into the over 600,000 mortality mark at 602,350 deaths, again from the start of the pandemic. In kids, as of June 17th, the data reported by the American Academy of Pediatrics says that we have just over 4,024,000 total cases from the start. That is 14.2% of the total number of cases reported in this country, and that comes out to 5,347 cases per 100,000 pediatric population. Importantly, and this is perhaps the bigger number to follow right now, the last week of pediatric cases accounts for over 24.6% of the new cases. This number has been that high even several weeks ago, had dropped just a little bit, but is climbing back up again. Likely this suggests that as our higher risk adult patients get vaccinated and do not then present for medical attention, that the remaining reservoir of disease, i.e. pediatric patients up to age 12, are now accounting for bigger and bigger percentages of the total numbers of new cases. Here in Arizona, we remain at the number 8 spot countrywide in terms of cases per 100,000. Our cumulative total number of COVID-19 cases birth through age 19 are 145,844 total cases, which is 16.4% of the total cases in the state. That comes out to 7,932 cases per 100,000 pediatric population. So once again, as stated in the last podcast, that the numbers of new cases and thankfully the numbers of deaths and even hospitalizations have all plateaued and are decreasing to the lowest spot yet since truly the recognized beginning of the pandemic in the United States. However, we are also dealing with the potential impact of new variants, monitoring very closely the impact, as one of the questions asked, of the Delta variant, that being the 1.617 subvariant 2 from India. So we're going to jump right into that question. Question 1, what is the advice on the emergent Delta variant in Arizona? And how do we persuade families to still proceed getting the vaccines for themselves and their children, knowing the vaccines won't fully protect those individuals from this strain? Well, as it turns out, indeed, Arizona, and in fact, the several biggest counties in terms of population have all recorded their first Delta variants, the variant from India. And indeed, we know from data in the country of India and certainly from the United Kingdom that this variant is 60% more contagious than the Alpha variant, which was or is the B1.1.7 from the United Kingdom, which we also have as the predominant strain in the United States. So every step of the way, each new variant, and the Delta variant is the best example, is more contagious than the last. Kind of makes sense as these variants are emerging via natural selection in the setting of some vaccine coverage. But vaccine coverage is nowhere near that necessary to reduce the viral load, and therefore nature will continue to fill that vacuum with new variants. I say that because, indeed, I think our messaging needs to be, we still need to be pushing vaccinations to try and get our current numbers even lower than they are to reduce the selective pressure for yet more variants. Importantly, also, the vaccines currently approved by emergency use authorization in this country, in the United States, do have efficacy against the Delta variant, and specifically the Pfizer vaccine, which is the one currently approved for use in ages 12 and up, has anywhere from 86 to 90% efficacy. That's incredible against the Delta variant. And so it may be because of that the numbers of increase in this country with the Delta variant are far less robust than they were previously with the B117 from the UK. In fact, last estimates from the CDC yesterday suggest the Delta variant has climbed from 6 to just 10% of the total number of new cases in this country, which is a far less rapid rise than it was initially for the Alpha variant, that the B.1.1.7 from the UK. So how do we then turn this into messaging and counseling for our families? Well, I think that the first important message is that the vaccines still work. In fact, they work pretty darn well, and especially the Pfizer vaccine, with which we have excellent data showing up to 90% protection against the Delta variant. That is just a little titch, shy of the total protection of that vaccine against all the other strains combined. So I would hope that can be used to persuade families to proceed with vaccination. Also, continuing to realize that other variants and other virus strains of the SARS coronavirus 2 remain the prominent ones in this country, and especially the Alpha variant, the B.1.1.7, the vaccines we currently have licensed for use in pediatrics 12 and up, and certainly 18 and up, remain highly efficacious against those as well. So now is the time to vaccinate. Certainly we hope the FDA is rapidly reviewing the data that it now has from Moderna for that messenger RNA vaccine for use in ages 12 and up, and that vaccine safety studies for both Pfizer and Moderna in ages 5 through 11 and 6 months through 5 are rapidly acquired and submitted for approval. Now is the time to act quickly, and now is the time to get that viral load in this country down as quickly as possible. Okay, next question. How should we best be communicating the executive order, this being from Governor Ducey, ordering the banning of mask and vaccine requirements in universities compared with what is currently mandated or recommended in the university setting, meaning the MMR vaccines, HPV, etc., and so forth? So importantly, the three state schools, those being University of Arizona, ASU, and NAU, have as their requirements only the MMR, and even that has multiple personal exemptions allowable. All the others, i.e. the quadrivalent meningococcal vaccine, HPV vaccine, tetanus, diphtheria, pertussis vaccines, all those are recommended but not required. I would view, again, our messaging as somewhat similar. While the universities are not allowed to require the use of masks and vaccine against COVID-19, we as healthcare providers, based on prior experiences with other vaccine preventable infections, strongly recommend ongoing use of masks in those students who are not yet vaccinated, and certainly the pursuit of vaccination as soon as is possible for those students who are old enough. So I'm certainly not here to comment on the nature of the governor's order. I personally, this is my personal opinion only, I think that's ill-advised. And I think the universities, all three of them affected by the state's order, are finding ways to navigate that and still support aggressively doing the right thing. And I think that's what it boils down to. Doing the right thing for the safety of the individual student, and doing the right thing societally to protect the population of those who are college age and even younger age. Next question. I have some parents who are interested in the idea of COVID testing in schools, yet I still want them to be coming into the office. How can I balance this? I'm going to interpret the question as being about where to do the COVID testing. And in fact, COVID screening in general is not strongly supported at the federal level and certainly at the administrative level because, well, several reasons. Number one, it's going to be difficult to pick up those who are vaccinated because routine screening antibody tests are not focused at the actual spike protein that's being produced with the vaccine. So they may not detect the fact that someone has been vaccinated and therefore protected. But also, and importantly, there is an array of rapid tests out there, many with quite variable sensitivity and, more importantly, specificity. So a positive doesn't necessarily mean a positive, and similarly, a negative don't mean a negative. So I think that the school districts realize this, and certainly at the federal level, it is quite apparent that the true health impact of screening is far less prominent, far less reliable than it hoped to have been earlier in the days of the pandemic, when there were certainly significant numbers. So I think it's reasonable to have that conversation with the patient's parents, the school kids' parents, and saying, look, screening at the school level is not going to be of much benefit, mostly because it is a point-in-time test. That student could be contagious, the next day, or could have been contagious 3 days before. And so the schools and we as healthcare professionals realize that the benefit of screening at a point of entry, such as to a school, to a hospital, to a workplace, is really of limited benefit. In the place of that, parents, if you are interested, I am happy to have that conversation with you and to test in the office setting so that we can get you a valid estimate of the risk both to your child, your school child or others, and to yourselves in terms of the virus itself. So again, identifying we as pediatric healthcare providers as the trusted source of information, both for counseling, for answering questions, but also in helping making a screening diagnosis or looking at risk. We do it in other areas of preventative healthcare. I think now is another opportunity to carry that into the COVID-19 conversations. Next question. There are several experts questioning the approach to push COVID vaccines for children, and how do I look at that issue? This is a complicated issue, and I absolutely understand where there are many who are questioning or maybe asking to push pause on the current rapid approach to vaccinate every younger children in the United States. The rationale behind this goes as follows. We know historically, at the start of the pandemic and until recently, that children under age 10 and even perhaps age 10 to a little bit older typically have mild or a far more likely asymptomatic disease. So these are not the kids at risk for developing complications, even with comorbidities that would require hospitalization and put them at risk for death. That risk profile changes a little bit in the middle school and high school age population, so ages 11 through 17, but it is still in general a much lower risk than for adults and high-risk adults with comorbidities in this country and certainly elsewhere in the world. So the thinking goes, if there are many parts of the world that are either completely unvaccinated against SARS coronavirus 2 or have vaccine coverage rates less than 10%, should we not be harnessing globally all of our vaccine resources to vaccinate the rest of the world, reduce the viral load, reduce the risk of yet another highly contagious, potentially highly virulent variant from emerging? And that makes a whole bunch of sense, and certainly I could support that. The challenge is that things are changing rapidly so that children are no longer potentially the innocent, not likely to get sick victims of the next variant coming down the road. The Delta variant indeed does have strong evidence suggesting that even controlling for it being much more infective or contagious, it also has greater virulence and has a different disease phenotype. People with Delta variant COVID-19 are presenting in shock, multi-organ failure at the outset, and especially with coagulopathic changes, as well as encephalopathy and other newer or less commonly reported manifestations of COVID-19. Every time a virus changes, we have to wonder, will that also affect children negatively and far more likely than they had before? It's just not known because the studies are so premature in that. What is known, however, based on experience in South Africa with the B1.351, the South African variant, was that children were far more likely to be both infected, symptomatic, and contagious with that variant in that country, in that continent, than they were with other variants. So it may be that our school children are just as at the same, if not higher risk, of disease and bad outcomes as were adults in the earlier stages of the pandemic. And if so, then proceeding with vaccine right now, since it's available and being approved, is absolutely the right thing to do. So we have a personal question versus a societal question and a global question. I'm encouraged that President Biden and the recent G7 conference approved the release of 1 billion doses of vaccine to other parts of the world. This is, of course, if not a drop in the bucket, it's a splash in the bucket, but it ain't the whole bucket. We have a long ways to go. But I'm encouraged that through COVAX globally, that vaccine efforts are increasing precipitously. In that setting, and because the United States has already purchased and already has ready to deliver excess doses of the Pfizer vaccine, the one approved for age 12 and up, I personally, again, this is my personal opinion, not that of the AAP, although AAP supports this too. But I personally feel we should be immunizing our school children as rapidly as possible as soon as safety studies for even younger ages are released and emergency use authorization is provided. Certainly, our 12-year-olds need to be lined up in our office getting their vaccines ASAP, both for their own personal individual health and also for reducing viral prevalence and the risk of another surge in the pandemic in this country, which of course could precipitate another hypervirulent, hypercontagious variant. Okay, last question then. What is my best piece of advice for smaller offices with less staff to provide and manage everything surrounding vaccine logistics? Boy, this is, again, a fabulous question. I would suggest, and perhaps many who have already are in the middle of this would support this, that the major limiting factor for vaccine delivery in the practice setting is the number of doses that need to be thawed and their shelf stability at refrigerative temperatures. Yes, thank heavens the Pfizer vaccine stability has been re-examined, and I think we've all seen, if not, we will, that the vaccine appears to be shelf stable in the 1,000, 1,100 dose aliquots when thawed and refrigerated at normal 3 to 8 degrees Celsius or up to 42 degrees Fahrenheit at refrigerator temperatures. So, and they're shelf stable for 31 days. That's fantastic. If, however, as per this question, it's a small office with presumably not a huge throughput in patients who are vaccine age, it would be difficult to go through 1,100 doses of the Pfizer vaccine in 31 days. It would be my guess. However, if and or when the age limits become improved, and or a vaccine such as Moderna's, which is even more shelf stable for longer at refrigerative temperatures, once that gets emergency use authorization, then I think a small practice conducting a vaccine clinic or giving COVID-19 vaccines is quite reasonable. From personal experience in volunteering for drive-through shot clinics, the biggest benefit for getting high throughput, meaning ease of administration, ease of safety checks, was to pre-register the patients, which of course we all have the ability to do via our individual electronic health records. So if it's possible to pre-register, have whether it's us, setting up the vaccine appointment or the family going on and completing their part, and then even entering in like the lot number and the vaccine type, etc. If all of that can be done electronically ahead of the vaccine appointment time, then it simply takes, one person to vaccinate and one person to record the actual injection, and then you're done. So we were joking that the largest part of the drive-through clinics was the wait in line for the initial check-in. As soon as they got to our station, I timed myself. It was 42 seconds from pulling up, opening the window, burying the sleeve, pulling up the record in Epic, our electronic health record, and me injecting the deltoid. 42 seconds. And it took just two of us, me, the vaccinator, and then the person who's on the computer as the scribe. So potentially one could arrange with advanced logistical planning and pre-registration either a drive-through clinic or at the very least a clinic protocol to make the process, the logistics of delivering the vaccine to be as smooth as possible. The post-vaccine safety check, the 15 minutes, certainly can be conducted in the waiting room with either a staff person or the front desk person monitoring, because the patients waiting in their cars after receiving vaccines in the drive-through clinics were just sort of being peripherally watched by walkers, and it was up to that patient themselves to flag down for help if they thought they might have an issue. So positive reporting by the patient, pre-registration, having a plan, having assigned roles, which also helps with infection prevention, are all recommendations to create a process, to create a policy which might allow for small practices that are small number of staff personnel to actually conduct vaccine clinics and or even just routine vaccinations in the course of the day in combination with other vaccines. Brief word about combined vaccines. Again, this has been evaluated and is supported at every level. So the AAP, the CDC, and the Advisory Committee on Immunization Practices, the ACIP, all support co-administration of COVID-19 vaccine to our ages 12 and up, along with other vaccines that adolescent might need. Has the safety and efficacy been specifically studied yet? No, they have not. But based on other extensive experience with other inert vaccines, there is every reason to believe that the vaccines will be safe and should be seroprotective in the normal time frame related to just the COVID vaccine and the other vaccines independently. So that is it for the questions. Once again, thank you for listening to ID Talk. Arizona AAP members can submit questions for future episodes to covid@azaap.org. For more information and for resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. Thanks again for listening. Hang in there, everyone. Come on, the summer.